Gaurang Shah, sir, good evening.
Good evening, Mahendra. So now you're back?
Yes, sir.
Good, good. So today we are going to have three cases.
Mm-hmm.
Uh, so the first case, we are taking all the cases which, little complications post-operative also. So we will not stop only at the, surgical management, but after the surgery, what are the complications and how to follow up. So that also we will have to.
Fine, sir. Fine.
Fine, sir. So we just wait for 5-10 minutes till
Sure, sir.
Ganesh and Gite and all they join. And then
Yeah.
we will start.
Okay, sir.
Okay.
Sir, you are a host, so you can make anyone a host. I will be emitting to you, sir.
Okay, I'll do that. And
Okay.
at the end, I don't have to leave the meeting. No, I have to end the meeting.
Yes, sir. I will be the meeting till end, sir. But
You will be there?
I have to make a एक्चुअली मैं आपको होस्ट बना दिया सर किसी सर एक्चुअली फील्ड में था
Okay, okay. Take it, take
थैंक यू थैंक यू थैंक यू
it.
Gite, sir, good evening.
Good evening, bhai. Good evening.
Gite,
Sir,
Good
good evening,
evening.
sir.
good evening. We just wait for 4-5 minutes. Ganesh has joined.
दिख तो नहीं रहे, शायद नहीं ज्वाइन.
So once he joins, I will just telephone him in 1 or 2 minutes.
Okay, sir.
I will definitely.
Shall we start now?
Yes, sir. Dr. Bakshi is joining.
Hi, he told me that he is joining in 5 minutes, 5 minutes. So, but we
Okay.
can start with the history.
Yeah, sure, sir.
Okay. Swastik,
Good evening, sir.
yeah, who is answering today?
Dr. Shashwat, sir, Dr. Sai Krishna, sir, and Dr. Ajinkya, sir, will be answering today, sir.
Okay, Dr. Sai Krishna, Ajinkya, and
Dr. Shashwat.
Ashwat. Okay, fine.
Yes, sir. So, I will start in the first case. Good evening, everyone. Coming to the scenario, a 66-year male security guard profession presented with complaints of episodes of blood in urine for last 10 days.
Fine. So, Shashwat, this is the history. We don't want to waste much of the time, okay? So, you
Yes, sir.
tell us quickly, yes, tell us quickly, how will you, ask the history?
Yes, sir. Good evening, sir. Sir, regarding hematuria, I'd like to know the onset of hematuria and whether it was initial, terminal, or total, whether it was intermittent or persistent, and along with that, sir, any pain or whether it was a painless hematuria, if there were any passage of clots, if the clots were present, then the shape of the clots, whether vermiform or amorphous, and then along with that, any passage of tissue bits. Then also I'd like to know about any fever, flank pain, lithuria, lower urinary tract symptoms, history of any anticoagulation or antiplatelet intake, any history of trauma or instrumentation. And accordingly, sir, I'd like to proceed, sir.
Okay, Sai, you want to add anything to that?
No, sir. This is fine, sir. I'm also thinking the same way. And any
Okay,
history
so-
of previous issue of similar episodes are there or not? And how he got treated with that, like whether they are spontaneously relieved or he has taken any medications or any interventions were done, if he has previous issue of similar episodes.
Okay. Ajinkya, you want to add anything?
Nothing, sir. Just more negative history regarding any constitutional symptoms, facial puffiness, lower limb edema, abdominal distension, jaundice. History of smoking, whether he is a smoker or not. That's it, sir.
So, at the age of 66, what are the differential diagnoses you are thinking of? Because accordingly, you are going to ask the history.
Sir,
Sir,
painless, sir, painless hematuria in a elderly male, sir. It could be malignancy of the urothelial malignancy, probably of the CA bladder, sir. Then it could be, sir, vesical calculus. It could be, sir, BPH with benign prostatomegaly with the hematuria. It could be a benign or a malignant enlargement, or it could be an upper tract tumor, sir. And
Why BPH will cause hematuria?
sir, the veins are dilated, sir, over the gland, sir, and that can open up and cause bleeding, sir.
Yeah, prostatic varices they're called,
Yes, sir.
and sometimes they can cause a good amount of bleeding.
Yes, sir.
But for that, a patient should have a severe LUTS.
Yes, sir.
Okay.
Okay. Fine. So,
Stone
go ahead.
disease, sir.
Yes, sir. Sir, hematuria was painless, intermittent, complete. It was associated with clots, has history of similar episode in the past, and there is no history of taking blood thinners.
Past for how many days? How many months?
Sir, he had a similar episode 8 months back, sir. So I'll come back to it, sir.
So, you continue your history, then they will ask.
Yes, sir.
Okay.
So there was no history of fever, there was no history of vomiting, no history of lithuria, no history of facial puffiness, excessive breathlessness, lower limb edema, no history of jaundice, weight loss, loss of appetite, breathlessness, and backache. There was relevant surgical history. There was history of undergoing cystolithotripsy with the TURP 8 months ago for complaints of difficulty in passing urine and hematuria associated with bladder calculus. There was history of undergoing cystoscopy and VIU 5 months ago in view of difficulty in passing urine and thinning of stream. This was a video of cystoscopy and cystolithotripsy that was done 8 months back. This is the ureteric orifice on the right side.
Okay, fine. So this is a cystoscopy finding. Other than bladder stone, no obvious cause of hematuria was seen, right?
Yes, sir. Yes, at that time, sir, nothing was seen, sir.
Okay. And prostate was normal, no dilated veins.
TURP was,
and the
cystolithotripsy with the TURP was done. Yes, sir.
TURP was done. Okay.
Fine.
Patient is a known case of diabetes mellitus for 5 years. He's on OHS. Family history is not contributory, and personal history: diet is mixed, appetite is normal, bowel is regular, but bladder is regular, sleep regular, habits non-smoker, non-alcoholic, and he's a non-tobacco chewer. He doesn't chew tobacco.
Okay, so fine. So Shashwat, now this is a history. Patient has already undergone TURP. Patient has already undergone the cystolithotripsy. Okay, and
Yes, sir.
now VIU also. That is, he had a picture. So now, what is your differential diagnosis? What are the things that come in your mind with this history? That patient has undergone prostate surgery, patient has undergone cystolithotripsy, VIU, and now he has got hematuria. And that time, sonography, everything was, both the times it was normal. So what
Yes.
will be the differential diagnosis?
Sir, actually now I'd like to add, sir, it could be a case of prostatitis also, sir. Chronic prostatitis. I'd like to add in my differential, sir. And since it is a fresh case of gross hematuria, sir, we'd still like to keep urothelial malignancy in the differential, sir.
Okay. Anybody, Ajinkya, Sai Krishna, Swastik wants to add anything?
No, sir. I'm also thinking in terms of malignancy related to the bladder and upper tract.
Yes, sir.
So,
The
why-
history of the prostate, sir.
Why you people are thinking of malignancy?
Sir, because it is a painless hematuria and associated with amorphous clots. So painless hematuria,
Clots may be formed inside the bladder. When was the TURP done?
8
8
months
months
back.
back,
8 months.
When was the VIU done?
5 months ago.
5 months ago. Where is the malignancy then? Which malignancy will develop within a 5 months? In the lower tract.
Okay.
Because you are telling a globular blood clots. And if you are thinking from upper, then usually it will present with lower urinary tract symptoms as well as there is a pain due to clot colics, and clots are serpentine.
Yes, sir.
Plus minus that side flank pain. Maybe, may not. Depend upon the obstruction caused by the tumor if it is inside the ureter and or clot. So this type of presentation is not there.
Yes.
That means my question as the examiner is, you know the case history. That's why I are telling there is a your first diagnosis is urothelial carcinoma. I am not suspecting urothelial carcinoma in this patient.
No, sir, we'd like to change the order. First diagnosis would be, sir,
Because
cystoprostate.
5 months back, if you have done a cystoscopy, any urologist who does the cystoscopy, he will do everything, na? At least bladder. He
Yes,
will check all the things. While checking the bladder stone, he will check everything. He will not go inside and just fragment the stone and come out.
yes, sir.
So as far as the lower tract is concerned, malignancy, visible malignancy is ruled out. Possibility of CIS, yes. It is possible. Some red patches are there here and there. Cytology has not done. If you are still suspecting the malignancy, then go for cytology. Check out for the non-visible malignancy like CIS. It is possible. But on this history and with this history, at present, I am not suspecting urothelial malignancy. During the down the line, during investigation, if something come as a surprise to as filling defect in some CTIVP or some cytology positive, then it's okay for me. I can change my diagnosis.
Yes, sir.
See, in this case, patient has already undergone 2 times, in endourology procedure. Second thing is already stone formation was there. There may be cystitis.
Yes, sir.
Because-
Cystitis.
So first of all, it may be because of cystitis, the hematuria might have taken place. Second thing is, after TURP, there may be a bleeding, secondary bleeding from the fossa infection.
Yes, sir.
So there may be bleeding from the fossa also. Third thing that you can say is, yes, that either the malignancy was missed that time, it may be in some place where the cystoscopy when you do cystoscopy, you are not able to see that, number one, or because of the stone, the bladder mucosa, is irregular, and that is the reason you might have missed a malignancy. So then, and the last thing is because of the irritation of the stone, that also can change the lining, and it can cause malignancy. So that you should keep it as Dr. Gite said, last. And if you get, do the investigation and you find out something else, you accept it. So yes, sir.
Yes.
It is there now.
So the whatever defense given by sir, as I will agree only for the before VIU. Second time again you have gone inside at the end of just before 5 months. That means we have done the VIU, we entered inside the blood. You must have seen bladder also. No one will do just VIU and come out. So at present, there is no any supportive evidence for lower tract urothelial malignancy which is visible.
Yes,
For first TURP, you have done a sonography. That sonography may have pick up the malignancy, but it is here and there tumor of any size, 2-3 centimeter, 1 centimeter. Sonography may miss. Possible है सर जो बोल रहे हो डिफेंस फर्स्ट सर्जरी के बाद तक agreed है. So we will go ahead with the how will you proceed.
Sir, just may I say something? Just suggestion for the students. So at this case, if you see, presenting complaint is hematuria, okay, and you should make a DD as a taken patient as an individual. Okay, this patient has past history, 8-month past history. As Gite sir has said, TURP plus vesical calculus. Okay, so that dictum is that a painless hematuria is considered to be a CA bladder or until proven otherwise. It is only for those who does not have any previous history of any disease. Okay, so you have to put all those thoughts in an individual patient. Suppose that if you say this is the bladder mass is the first DD, you should know how to defend your DD in this patient, right? Whatever DD you make, you must be able to defend the sequence and the reason of DD. Why Gite sir refused the CA bladder as a first instance, and already all the causes he mentioned, because he is not thinking as a general, he is thinking as per this patient individually, right?
Okay.
Or you have to think very fast in the exam. The patient, sir pointed very well, this patient underwent VIU 5 times, right? And every time the surgeon generally goes into the bladder, at least bladder neck tak pahunchte hai. Am I right?
Yes, sir.
So these point, if you want, in this case, if you want to put your bladder cancer malignancy, maybe as a form of carcinoma in situ, that can be easily missed by unexperienced urologist, it should be the last DD. Whatever will come in the investigation is different thing. Urocytology positive, but based on the history, your DD should be very specific. Okay, and if you stuck in the history, believe me, your further viva will be affected badly.
Exactly.
Right? So individualize, as you know, this is the case of MIBC. Don't think like MIBC. वो तो it will come after investigations, right? Take this case as a case of hematuria who underwent TURP and second calculus surgery 8 months back, and who is regular in scopy findings. So VIU is going on. What other causes can be?
VIU was only once 5 months back.
Okay, even sir, 5 months back, even scopy was done on that time, and he
Yes.
does not have any risk factor like smoking, right? Not other factor for the bladder cancer.
Yes, sir.
Is it clear? So
Yes,
when
sir.
you
Yes,
when you approach as a symptom basis and history basis approach in making DD, you will be rarely wrong. Okay, and never get biased. Okay, sir, कौन सा case है? अच्छा MIBC है. Then when you become biased, then you do blunders. Okay.
Yes, sir.
Yes, sir.
Chalo. Now, can you again make the DD based on the history and symptoms?
So first differential will be cystitis and or a prostatitis, and it could
Why not he again develop a stone in 5 months?
Sir, possibility is there, sir, but lower down we'd like to also keep a vesicle calculus.
Because he underwent TURP and it a good surgery. TURP will bladder possibly develop after 10 to 15 years if the regrowth can cause symptoms. If TURP has been done in a very good manner. Right?
Yes, sir.
He is having a stricture key history. This definitely cystitis or other thing can be there, right?
Yes, sir.
Yeah. Okay, so approach individually based on the patient symptoms and the past history. Okay.
Okay, Swasti, go ahead.
Yeah.
Yes, sir. General examination, patient was conscious, cooperative, well-oriented, time-place person. Pulse was 80 beats per minute. Karnofsky scale was 90. BP was 130 or 70. Respiratory 18 per minute. Febrile. Saturation was 99% of room air. No evidence of pallid rectus, sinus, clubbing, lymphadenopathy, and edema.
In this case, I would also like to know about the HPR of TURP.
Yes,
right? Just but complete your history, everything. Okay.
Yes.
Okay. Yeah. First, continue.
So, the patient examination, per abdomen examination, patient examined supine position with implied informed consent with exposure from nipple to knee in adequate room light. On inspection, umbilicus was centrally placed, all quadrants were moving equally with respiration, and no scar, sinuses or engorged veins were seen. On palpation, there was no local rise of temperature, no tenderness present, and no bladder was palpable. On percussion, tympanic note was present all over abdomen. Normal liver dullness span was present. Auscultation was normal, and normal bowel sounds were present. On parectomy examination, no fissure, fistula, or hemorrhoids were there. Anal tone was normal, prostate grade 1 enlargement, firm, smooth surface, and rectal mucosa was mobile, no blood on gloves. Sir, I can just tell that HP reports are actually it was a benign prostatic tissue, sir.
Okay, fine. That's okay. With that, you people should ask this thing. Okay.
Yeah. Whenever the biopsy is done, you always ask for that. Otherwise, we'll miss something.
Yes, sir.
Fine. So now, depending on this, what next? Shashwat, what we like to do? You want to do any other examination or you want to do anything else?
Sir, I'd like to request a complete urine examination along with CVC and renal function test, sir, and an ultrasound of the abdomen and pelvis, sir.
Okay, but now is the case of hematuria.
Yes, sir.
So you want to do ultrasonography because ultrasonography was done earlier also. Do you directly want to go for CT scan or any other test you want to do?
Sir, after the sonography initial report, I'd like to request if some cause is found or it's according to the reports, the urine cytology and upper tract imaging
now,
also.
First of all, I want you to justify ultrasonography, number one, and how it is going to help you. As usual, you say that it is an extension of my clinical examination, and I'd like to do it. Second thing is, suppose if it turns out to be ureteric calculus or vesical calculus. You may
Yes,
not do like, full abdomen pelvis CT scan
sir.
with the contrast. But if it is not there, some other growth is there, definitely you like to. So your CT scan also depends upon the findings that you get on ultrasonography.
Yes, sir.
So you have to defend yourself in exam, whatever you say. Suppose by chance you say, I don't want to do sonography, you will have to defend.
Yes, sir.
So how will you defend, Ashwin, in exam?
Sir, in Sono, sir, in this case, it's patient has been operated twice, sir. So,
So operated twice. It doesn't, imaging was not done or done.
probably, sir, lower urinary tract cause of bleeding cannot be there, sir.
I
So-
asked, how will you defend about sonography first or CT scan first directly?
Sir,
That's simple. He
CT scan-
underwent. Yeah, go ahead.
CT scan, I don't think so, sir. Should be the CT urography should be the first investigation for this patient, sir. First, I'd like to know the organ of interest. Probably, patient is having some hypoechoic collection in the prostate, or it could be a vesical calculus, or I can
Yeah.
find out some hydronephrosis. Accordingly, sir, I would like to proceed to our CT scan, sir.
Yeah, so there is there is no rule that you do always USG first followed by the CT scan. This is not a rule. Suppose that the patient underwent ultrasonography 2 months back.
Yes, sir.
And he has a hematuria. So that sonography is not going to pick up anything at the 2 months. In those cases, you can go ahead with the CT scan directly if it's available. Okay.
Yes, sir.
And suppose that if his USG was done 8 months back, 9 months back, USG sonography, then you are justifying to do sonography first. Then you can plan for a specific CT if needed based on the USG findings.
Yes, sir.
Okay. And how to defend it? It is easily available compared to CT scan. Okay. So that can be the first investigation. And it does not need any special blood test. It just needs experienced sonologist.
Yes, sir.
Okay. This is
Yes,
how you can defend both the things. Okay. Yeah.
Yes, sir.
Okay. What else you want to do in this case of a patient with hematuria other than CBC, urine microscopy, routine microscopic, and sonography?
Sir, urine cytology is also indicated, sir. And if required, sir, upper tract cross-sectional imaging.
So that sonography will be we are doing na sonography. Any role of serum TSA in this case? 66 years of age, even PR is normal.
Unlikely, sir, but if we are suspecting prostatitis, we may request a serum PSA, sir, also.
Okay. We may or may can be optional.
Yes, sir.
Yeah. Okay. What was done?
So answer to Dr. Mahendra's question in exam is I will offer the PSA and it will be shared decision by patient as well between the patient, me and patient. If patient is willing, I will offer the PSA, provided that there should not be any recent cause for increase in PSA, which is iatrogenic, like instrumentation, catheterization, retention, something like that. वैसा कुछ रहना नहीं चाहिए. ठीक है?
Yes, sir.
Yeah.
So on blood investigations on hemoglobin is 10.3 grams per deciliter, TLC was 9,000 per deciliter, platelet count was 3.1 lakhs, serum creatinine was 0.8 milligram per deciliter, PSA was 1.3 milligram per ml, nanogram per ml.
Yeah, अभी तक एक DD was infection with something, na cystitis. Hello.
Yes,
Yeah,
sir.
yeah. Yes, sir. Yeah.
Then why? Then ideally you should not do a PSA.
Yes, sir.
I mean, my thought is like that. If your DD is infection, urinary tract, then you should not venture in doing a PSA. It is normal here. That's a different thing. That if you are discussing as DD1 infection, UTI, then it is the wrong for you.
See, the earlier also, as Ganesh is saying very rightly, earlier also PSA was normal. We have already done QRP. Biopsy is not showing. Of course, it may not be representative of the full pathology, but it is not suggestive of histopathology. Is also not suggestive of any malignancy. So, within 8 months,
normally we are not going to get this positive report.
Usually, last intervention is 5 months back, and currently they have multiple clinical diagnoses, and no any signs and symptoms suggestive of there is a local tenderness. There is no local cystitis diagnosis. There is no any local tenderness, no any fever. So it can be uncomplicated cystitis possible. I'm not denying that. But offering a PSA for 66-year-old with doesn't have any signs and symptoms of active infection, offering is probably may not be a wrong idea. He will take that or he will not take that. That is a different issue.
I agree, but sir, वो ना इसमें अगर urine routine normal रहता and then you ask for a PSA, it is much better.
Agreed, sir. That I agree, sir.
Right.
Ruling out infection is primary requirement.
मतलब एक DD है इसलिए बोला मैंने, बाकी कुछ नहीं मतलब. That there the students will get caught.
I agreed, sir. Agreed, sir.
So we'll proceed.
Can I ask you something?
Yes,
sir. बोलिए.
I would feel that unless the diagnosis is prostatitis, let's not mix up UTI with prostatitis. So why is PSA contradicted in UTI? It is contradicted in prostatitis, I agree.
Sir, कई बार UTI में PSA high आता है. So many of these people whom we treat, even with cystitis, those will end up in our OPD with a PSA of 20, 25. You just treat the cystitis and the anxious का मतलब PSA 1 पे चला जाता है.
Okay.
Yeah, we have seen, sir, those cases. Maybe 60, 70 like that serum PSA infection. Yeah.
And then मतलब the duration of antibiotic is also not so long actually to treat the prostatitis. मतलब I believe that prostatitis will need at least 6 to 8 weeks of therapy. But ये 15-20 दिन में PSA नीचे आ जाता है.
Hello.
Fair.
Hello.
Sir, bolo.
Sir, I also agree with Dr. Ganesh because we also face this problem in prostatitis. We get PSA up to 40, we have seen. And then ultimately after treatment, it came to normal and he was negative for malignancy.
मतलब पंकज सर दूसरा एक चीज है ना मतलब many patients will come with overt symptoms of UTI मतलब burning, dysuria वगैरह मतलब and not the classic kind of perineal pain वगैरह of prostatitis. उनका भी कई बार मतलब high रहता है and you treat them and they are suddenly better. I mean better with the PSA.
बराबर.
With the symptoms.
ठीक है. Okay, agreed भाई.
Agreed, sir.
So go on.
So urine routine microscopy was done. Proteins were present in the urine. Occult blood was present. Pus cells were the high power fields were full of pus cells, and red blood cells were 8 to 10 per high power field. Epithelial cells were 2 to 3. Cast and crystals were absent. Amorphic bacteria yeast were absent. Right, so we also did urine cytology for which was we showed suspicious of atypical cells. The cells were having enlarged nuclei with degenerative nuclear chromatin and moderate cytoplasm. We did sequential 2-day cytology, sir, on consecutive days. Urine culture was negative, sir. We also did sonography.
How do you explain that? वो urine routine microscopy full of pus cells ऐसा कुछ लिखा था.
So it is sterile pyuria.
Pyuria. मतलब what can it be? Tuberculosis?
Stone tuberculosis and malignancy.
Sterile pyuria with hematuria.
Protein 3+.
Many a times these patients, they are on a long-term antibiotic. because they have got a stricture, they have been treated. So he might be having some symptoms. So he was on long-term antibiotics. So that might be the cause.
Okay. Difficult case है exam के लिए बहुत.
Yeah.
Okay. Go ahead.
Yes. So cytology was suggestive or suspicious of the typical cells in both the samples, and the culture was negative. And this was a sonographic.
Okay. Can you read sonography? Do you know how to read sonography?
Yes, sir. These are the, sir, plates show ultrasound of the KUB region, sir. The bilateral kidneys appear normal in contour. Corticomedullary differentiation is maintained.
What
And,
abnormality you can see? What abnormality in this case?
sir, in the bladder plate, sir, we can see a large sessile wide-based growth in the left lateral wall, sir, rising from the left lateral wall. And no other clots or any calculi are seen in the bladder.
Is it not prostate that is bulging into the bladder lumen? Having some irregularity over it, and the involving the trigonal area at the bladder neck, if you see trigone actually. You should know, you should learn how to read sonography. Okay.
Yes,
Better every time when you see sonography report, just try to see the pictures and correlate with the reporting. Okay.
Yes, sir.
Yeah. Okay. So what was the report?
So right kidney was normal in position in the morphology. Corticomedullary differentiation was maintained and no evidence of any calculus detected. No corrective system dilatation was seen. Similarly, findings are on the left side. Urinary bladder showed a distended and shows normal lumen. Focal wall thickening measuring 3.2 centimeter length and 1.5 centimeter thickness was seen on left lateral wall. Pre-void was 321 cc and post-void residual urine was 60 cc. Prostate was normal in size with midline defect consistent with previous URP. So impression was focal thickening of left lateral wall of urinary bladder, cystoscopy, and position was significant post-void residual urine was there, sir.
Okay. What will you do now?
Ajinkya?
Yes, sir. Cytology report is both two reports are suggestive of typical cells, and the ultrasound is suggestive of a focal thickening on the left lateral wall. Sir, I'd like to go ahead with cystoscopy and further decide, sir, whether there is thickening or if there is a lesion inside the wall.
To all the this thing, Maheshwari and Ganesh and Mahendra. Now already this patient has undergone 2 times scopy and now he has got a hematuria. So after ultrasonography in this case, we should go ahead with the cystoscopy or we should go ahead with the CT scan.
So sir, I was just coming to this question. Yeah, just you said like that.
CT scan.
Yeah, what you should do now, because sonography we can miss something at the upper track. Okay, and already we have seen the CT scan, and once we do cystoscopy under local, it is okay. We are not doing any procedure, but we are doing under GA. Then we will do also TURBT, and then doing the TURBT after that, it will create artifact. If we do CT scan after that. Okay, so I think in this case cystoscopy is to be done, but before that we should have a full CT scan abdo pelvis to see the where the site of hematuria is. Bakshi sir, want to add?
CT scan.
Yeah. So nowadays that if hematuria is there,
focal thickening is like you should take it like sonography. So it is best to see that focal thickening with its proper morphological features in a CT scan. I would suggest that. option to think about this is a MR.
Yes, sir.
So only thing is that MR is still evolving. So there are many people who strongly say I would do an MRI, but then you will be asked why you want to do MRI before you don't know anything. So you can say that the bladder can be delineated or properly seen. But the only point is that it's just a focal thickening reported. So what we are also hinting at is we need to see the upper tracts properly. So one of the investigations which we can read easily is a CTI view. This dilemma is going to remain now for the next 4 or 5 years. Till it is sure that MRI should be done or CTI view should be continued.
So, sir, I think it's still today MRI is only indicated in the patient contrast to allergy and other thing. Otherwise, as for diagnosis purpose, T2, T1, I think still MRI is not
CTI view.
standard of yeah.
Okay.
Now,
Swastik, show them.
Ganesh, let me again take a contrary opinion just to get your thoughts on this.
Yes, sir.
Sonography showing upper tracts normal.
Yes, sir.
What is the possibility of there being upper tract tumors with sonography normal?
And we can always miss upper tract tumors, but even the focal thickening will be seen better with an axial imaging. I mean, he is operator dependent, and somebody who will say focal thickening might be something different.
Okay.
Sir, one
As
more.
far as
Yes, sir. Sir, आप बोलो, Gite sir.
as far as local staging is concerned, MRI and CT scan are equivalent. I may say MRI is better than CT scan for local staging. But no one can, both MRI as well as CT cannot diagnose the microscopic invasion outside in the perivesical fat. So here MRI can be defended, as Ganesh Bakshi sir is told, but considering the hematuria and local only focal thickening, if I am a student in exam, I will prefer CT over MRI. CT will help in giving more details about upper tract compared to MRI and surrounding of the bladder. So CT will be better than MRI. But for local staging, MRI is better than the CT.
Yes,
Rather, exactly this is what I want to say, that you see with sonography normal, the possibility of having major lesions. You see, my one more thought is that in exam, if suppose a sonography report is given, which is normal, can I really doubt that report? Okay, we can't say that it is operator dependent. Sonologist may be poor. When a report is given, we have to take it on face value that, okay, this is the report given where they have said that it is normal.
You are right, sir. I agree with that. But
When we are told that upper tract,
thickening-
then let me complete.
Yes, sir.
When we are told that upper tracts are normal, now my more interest is to really stage or have a better imaging of the lower tract. And that is better with MRI. So I would, with a sonography showing upper tract normal, I would insist on a MRI, not on a CT scan. That is what I was thinking, but I want everyone's opinion on this.
Only CT is a standard investigation, and if I say in other sentence, MRI is still evolving.
True.
So that can possibly help in the exam also.
Yeah, and exam defending CT is easier because just history of hematuria itself, there becomes an indication for CT scan.
We have talked a lot about MRI, but everywhere, they are not contemplating MRI or they are not discussing. So in exam, it is a, better way to talk about a CT scan rather than MRI. And if the examiner asks, then I think we can talk about MRI.
If examiner asks which is the best investigation for local staging, MRI.
So the student should know about both the things.
Okay, sir.
Fine. Okay. Swastik, show them CT scan.
We did a CT scan, sir. This is a plain film. I will go through the slides, sir. Control stone. Control please.
We'll see the report.
Sir, should I go to the report, sir?
Yes.
Okay, sir. So the report showed that both cases were normal in position, size, and CT morphology. Renal cortex and medulla are normal, and normal excretion was seen on either side. No calculus or hydronephrosis in right kidney. Right ureter was normal. No calculus in the left kidney. There was mild fullness of the pelvic calyces system in left kidney. The left ureter is dilated in the entire extent up to the UV junction, left UV junction. Urinary bladder was well distended. There was focal plaque-like enhancing soft tissue thickening along the left posterior wall of the urinary bladder with involvement of the left UV junction. The rest of the bladder wall shows normal thickness. Mild sticking of perivesical vesical fat was noted. Sub-centimeter size left obturator lymph node was noted. Prostate was normal in size. The liver, gallbladder, pancreas, spleen, and bowel loops do not show any definitive abnormality.
Shashwat, next what?
Sir, I'd like to counsel the patient, and I'd like to about the CT scan report and findings. And then, sir, I'd like to proceed to obtain for a cystourethropy and if required, TURBT, sir.
So, Shashwat, as per the CT scan finding, what do you think? What type of disease it is? Muscle invasive or non-muscle invasive?
Sir, actually, CT scan cannot reliably tell about T1, T2, or T3A staging, sir. So, very difficult to comment on the T staging, sir. From TA to T3A, same, sir. But
So what is
since
the,
it is,
then what is the use of doing CT scan if he cannot differentiate T1, T2, T3?
sir, there is an
Therefore-
indirect evidence of muscle invasive disease, sir, because there is left hydroreter nephrosis, probably the left UVJ is involved. So that is an indirect evidence of muscle invasiveness, sir. Apart from that, sir, there are subcentimetric obturator nodes. So
Yes, why I highlighted these points is that where we can avoid something. I mean, MIBC, what is the ideal management? TURBT or some radical thing?
sir, ideal management is definitely, sir, neoadjuvant and radical surgery, sir.
Okay, so in the CT scan film, we can differentiate between the T3 disease and T2 disease. Periocycle fat is trending. And can we go back to the CT scan images?
Yes, sir.
The axial images, yeah. The non-contrast one. And not excretory phase, the previous one. Yeah.
You can watch.
So if you can see the normal bladder wall thickening and the normal smooth surface of the remaining bladder wall and compare it with the disease part is there.
Yes, sir.
Do you think
contour is abnormal, sir?
do you not think if suppose that tumor is not there, the line of the wall, it will follow the mass is involving the full thickness of the bladder wall?
Yes, sir. Most likely, sir.
Okay, so see how you are contradicting your statement. You first said CT scan cannot differentiate T1, T2, T3 disease. Okay, and now you can easily see that the tumor has gone beyond the normal bladder wall contour.
Yes, sir.
Okay, definitely by CT scan we cannot identify the histopathological diagnosis. Okay, but for T stage definitely we can identify it. Okay.
Yes, sir.
Yeah. So now my next. So what was done in this case?
So the patient was taken for a cystourethroScopy and TURBT was done. And
Okay.
the histopathology was suggestive of a high-grade urethral carcinoma. Lamina propria invasion was seen, and invasion to deep muscle was also seen, sir.
So it was a proper TURBT or just the biopsy was taken, or a proper TURBT was done?
There were, yes, sir, multiple bits were taken, sir. Proper TURBT was done, sir.
Okay. Okay. Fine. Now, what is your plan? Now you have
Ajinkya, what is your plan?
You have a biopsy, TURBT, histopathology report. What is your plan?
The patient on TURBT is showing high-grade muscle invasive urethral carcinoma. So, like to counsel the patient regarding the disease what he is having, what patient is having, and I like to go ahead with neoadjuvant chemotherapy followed by considering patients' performance status and age. We like to go ahead with neoadjuvant chemotherapy and radical cystectomy with pelvic lymph node dissection.
Patient is too much afraid.
Yes.
You explained we will remove your bladder after this, after chemotherapy, you need chemotherapy, and he just get panic about the chemotherapy. Chemotherapy will make me bald, and so many complications are there. I have seen my relative dying after chemotherapy. Then you were right till I will explain the disease status and treatment. Treatment options. There are two treatment options at this stage.
Yes,
Tell me what.
one is NSCT, neoadjuvant with radical cystectomy and pelvic lymph node dissection with and
second, upfront cystectomy if he is not fit for chemotherapy.
Not fit for chemotherapy.
What is third one? Which is weak recommendation, but should be informed to the patient.
Bladder preservation
bladder
therapy.
preservation therapy.
Yes. Okay.
Yes.
Then you whenever patient comes, okay, you have to, again I said, you have to treat patient this thing individually, and you have to explain whatever available, because patient will say, I was not informed about the bladder preservation. I would have selected that only.
Yes, sir.
It is a part of counseling and part of management, right?
Yes, sir.
Yes, sir.
And with pro and cons of each therapy, radiation is not as equal as a surgical treatment. Data is evolving, but definitely at 5-year data, it is equal. But the long term, we do not know. It should be again shared decision. Okay.
Yes, sir.
Yeah.
Actually, in bladder preservation, sir, hydronephrosis, it was written, it is a
right. I agree. But suppose that if it is not, so it is to make your habit. You should explain all these things.
Yes,
whatever is available in the treatment, whatever cancer is there, the prostatic cancer or other renal cancer, anything. Okay.
Yes, sir.
Yeah. Okay. Sir, कुछ ऐड करना है, डॉक्टर बख्शी सर?
नहीं.
Okay. Yeah.
Okay. So
yeah.
So we did what? Swastik, just tell them what we did.
We did a radical cystectomy with lymph node dissection and with a intercorporeal ileal control. We did the procedure robotically at our institute.
Fine. So my question: why the chemotherapy was not given this case neoadjuvant setting?
So the patient chose to undergo a radical cystectomy upfront rather than going for neoadjuvant chemotherapy, sir.
Okay. So, Bakshi sir, I don't think so. There is
if the examiner asks same question, I will defend like I will prefer to give a neoadjuvant chemotherapy in this patient that it is indicated for T2 to T4A N0M0. Here N0 because they are subcentimeter lymph nodes, and after assessing the metastatic, after doing the metastatic workup, if it is M0. It will give, why you offer a new adjuvant, then it will give additional 8% benefit at the end of 5 years. That will be my answer in exam. Practically, radical cystectomy upfront, I personally feel the neoadjuvant chemotherapy should be given to this patient, and it is opinion for the others.
Yeah. So in exam, the answer should be same, and examiner may ask, what about the adjuvant chemotherapy? So if patient is not receiving chemotherapy now, will he receive chemotherapy later?
Only if, sir, the final pathology is showing some high risk features like margin positive or lymph node positive, so then we can add on the
I
adjunct.
think T3A and T3B also indication of adjuvant
Yeah,
chemotherapy.
yes, sir, adjunct.
And by the CT scan, it appears to be a T3A
Yes,
disease,
sir.
right?
Yes, sir. So
here in exam, whatever are the protocols are there, you have to follow that. Okay. And somebody asked specifically, then you can say, in my institute, some patient asked, and I have seen that they also defending way actually. Okay, how you can defend yourself. The last option in my institute, this protocol was followed, but the guideline says this. Okay.
Better you read the mind of examiner what you want.
Yeah.
If you want, if he is towards the neoadjuvant chemotherapy, better tell neoadjuvant chemotherapy. If not, then in our institute, it is a protocol to go ahead with upfront or early cystectomy followed by adjuvant chemotherapy. If you are not giving a chemotherapy by neoadjuvant way, it can be given by adjuvant way. If it is a PT3 or T4 or lymph nodes are positive, or the chemotherapy is not given preoperatively, that is an indication for adjuvant chemotherapy. That can be defended, but better you should tell like a neoadjuvant chemotherapy. That's what I feel. Ganesh Bakshi, sir, your opinion.
Nice, sir. Barabar hai. I agree with this opinion.
Okay, Ganesh, one question. But that if no, forget about exam. What Dr. Gite is saying, the student should say like that. But in a practice, like when you come across such cases where multiple time patient has undergone surgery, he's tired, he doesn't want, he's afraid, and he says that now I want my bladder to be out because I don't know since how many months this disease is there. Okay, so in that case, are we justified not to give neoadjuvant and do the early cystectomy?
Sir, original data goes in favor of neoadjuvant chemotherapy. There are abstracts presented at AUA in certain cases of T2, N0, M0. You can go ahead with upfront cystectomy and then see about it. The whole logic in giving chemotherapy is to take care of micrometastasis.
Sir, can I add something in this?
Yes, please.
Yeah.
So in this scenario, there should be a shared decision. If patient is afraid of chemotherapy, he doesn't want to know, it is a doctor duty to explain him what is the recommendation. It has to be given. It should be shared and to be documented properly as a medical legal part. Because something is as per guidelines, and you are not doing that. Only verbal communication is very harmful in future. Maybe after 6, 5, 10 years, you will get some notice from the court case why it was not given when it was a standard of care on that time. So again, okay, agree. If patient doesn't want chemotherapy, okay, you can do surgery, but there must be a proper documentation with the proper consent. And I have been told about that. Not receiving neoadjuvant therapy may affect my recurrence or survival.
Whatever the defense given by Gaurang Shah sir is okay practically. Majority time it will be done, but this patient or such type of patients requiring adjuvant chemotherapy, there are high chances. In such situation, after doing the radical cystectomy, if he is not willing for neoadjuvant chemotherapy now, then chances of willing for adjuvant chemotherapy again, it is there is again question in front of the both treating physician as well as the patient. Adjuvant chemotherapy to be given or not to be given. If he is not willing, the not willing may not be the answer. Whatever the guidelines, you have to write on the paper, and if he is not willing, then it's okay. We have to take an interpretation and do practically what we were doing. We are also doing the same thing. Our referral to neoadjuvant chemotherapy is very less, not as like a Tata or Ganesh Bakshi sir or Mahendra, but theoretically it is there.
Sir, we do the same thing. We do, if any patient is asking out of the by the guidelines, we explain them and put on the EMR and document on the EMR. In future, nobody can say we did something wrong, which is not done to the patient. Okay, so this is the practical thing for the let us now.
So now, Shashwat, after this surgery is done, how we are going to monitor this patient post-operatively?
Sir, once I want to ask
step.
something. So, patient plan for radical cystectomy. So, please tell me the indications and contraindications of doing cystectomy. Contraindications of cystectomy.
So the indications of radical cystectomy are T2 to T4A clinical N0 M0 disease. Then it could be, sir.
Okay, that is fine. Sorry, my question wrong. Tell me the contraindication of cystectomy.
Contraindication, sir. If patient is unfit for radical surgery, sir.
Okay, maybe cardiac LVF, EVF is the 30-40% not fit for surgery.
Or sir, it's a T4B unresectable disease, sir. If we find gross or periuretral or rectosigmoid invasion is there.
So when things come like the operative thing, you should know the contraindications. Serum creatinine should be that much, minimum this much. Okay, no Crohn's disease, right? Because you're going to use ileum. There should be no diverticulum disease of the ileum.
Yes.
Okay, there are few contraindications. The same applies for the neobladder.
Yes.
Okay. So, what type of neobladder you would like to do for the neobladder?
Sir, ileal neobladder would like to do, sir. Studer pouch.
You should know the name. I'm not going to the deep into this issue, this topic, but you should know about all the describe neobladders and what are now commonly done and what you have seen in your institute. Okay.
Yes.
Along with each neobladder, either jejunum or the gastric or the ileum or the colonic, has their individual metabolic complications. Okay. How to monitor their technique, how to monitor that complications, you should know. Right?
Yes, sir. Yes, sir.
Length, how much length is taken, that is very important. Okay.
Yes, sir.
The principle of reconstruction of neobladder, right? It's all you should know. So now tell me, how will you going to observe this patient post-operatively? As Gaurang Shah sir asked.
Now you just tell me on day 1, day it means how you are going to manage.
Asha, one more thing, topic, sir. In this surgery, there is ERAS is there.
Yes, sir.
Right. So definitely, examiner may catch you in this ERAS. What is ERAS and how it works? What is the principle behind? Yeah.
Sir, it's a fast track protocol, enhanced recovery after surgery protocol, sir. It is aimed at fast recovery and minimizing gastrointestinal and post-operative ILS, sir.
You read because in uro-oncology, I think radical cystectomy and partial nephrectomy, two papers are there on the ERAS, right?
Okay, sir.
So read that start from the pre-anesthesia, then anesthetic, pre and post surgery. Okay.
Yes, sir.
Read that properly. Okay. Note down that you should know about the ERAS in radical cystectomy. Okay, and neobladder.
Yes.
Okay.
So as far as when cystectomy is discussed, you should know the preoperative optimization of the patient, then perioperative mechanical or pharmacological prophylaxis, then importance of the number of nodes or extent of lymph node dissection. Then in female, if it is uterine sparing, or in male it is not sparing, and pouches. So these questions once in a while can ask in exam.
another question, LND extension, yeah, template of pelvic lymph node dissection.
Agreed, sir.
Yes.
Right? ये
Yes,
बहुत
sir.
ही controversial, it's a very controversial topic. You should know what is done all over the worldwide, commonly done. There's no consensus about it. How much node to be removed, average. You should know these things. There are one-line questions, but they are give you full marks.
Yes,
Okay,
sir.
if you know.
Yes.
Yeah. Okay, fine. Now the Gaurang Shah sir asked how we are going to do the patient post-op management day 1, day 2, day 3. Tell us.
So post-operatively, we are going to evaluate the CBC, the hematocrit, and the creatinine and the serum electrolytes of the patient, sir. Along with that, we like to keep charting of the urine output, and sir, we'd like to promote chest physiotherapy and early ambulation of the patient, sir.
Okay, day 2.
If the bowel sounds are present, sir, the patient is passing flatus, then SIPs can be started, sir.
In second day.
Sir, if the patient is passing flatus, sir, usually by 2 to 3
You
days.
expect him to pass flatus on second day?
Usually no, sir.
Simple question. After any bowel surgery, small bowel surgery, in general surgery, when will you expect patient should pass the flatus? Leave
Sir,
it that
after 72 hours, sir. At least 72 hours usually. 3 to 5 days, sir, they take, but after 72 hours usually they pass, sir.
Yeah. So minimum 48 hours, at least 2 days. Third day, fourth day, patient may pass flatus. So that is what you are expecting.
Yes, sir.
So I feel that once patient pass flatus, okay, then you can decide regarding oral SIPs, means liquids.
Yes,
so you'll go slow on him because we
So,
have done the bowel resection also.
Gaurang Shah sir, here ERAS comes. Okay.
Huh.
What ERAS says, our bowel secretions are already in liters per day.
Yes, sir.
Correct.
Stomach to the to the small intestine jejunum, they're in liters and they cross our anastomotic line. Okay.
Fine.
So we should not stop taking oral SIPs. Yeah, we should stop taking the quantity of the oral SIPs, because if patient has a Ray's tube, it will irritate the throat. So patient may have some irritation like that. So it is also to make throat wet. We can start something 120 or 200 ml per day, day 1. Okay, because it will also give a patient good feeling. So MBM is only for 24 hours. And now the ERAS says remove Ray's tube, day 1.
Yeah. So I agree with you. So it is a very limited fluid that we are giving, that we also give about, like, we can say that 30 cc per hour. Normally, that is what we are recommending.
So sir, what now I do, even sir, Dr. Bakshi sir also agree, we start giving, if it's non-diabetic, Glucon-D electrol or maybe Epi juice we started giving day 1. Some small sips. Yeah.
Okay.
But not a full packet, maybe half packet in a day or like that.
Okay.
Yeah. Okay.
Fine.
Then
so go ahead.
Going ahead, sir. In post-operative period, patient had developed abdominal pain and distension along with vomiting and observation on post-operative day 6. So patient was worked up and was diagnosed with intestinal obstruction.
Okay, just I want to interrupt something, the practical thing. The first line, the post-op period patient develop, post-op day 6 develop vomiting and distension. So what is the, which in my experience, different cause other than the mechanical obstruction, is the patient is in ileus, and when we do not instruct him that how much water to be taken, so these patients take water in bolus. That means 1 liter of water they take in a day, and then they vomit. Okay, so there is the importance of whenever you allow orally, increase the amount gradually and keep watch. They are drinking that much amount only. right?
Right.
Yeah. Okay. Now this is workup for okay, maybe CT scan was done. I think so.
It was
Yeah,
done.
yeah.
Okay.
It is. So we don't have the image of CT scan, sir, actually.
So now the here question comes: what are the causes of uterine obstruction in a post-cystectomy patient?
Shashwat,
Then it could be post-operative.
Sai, you have not answered since long.
Yes, sir. Sir, it may be because of herniation of bowel loops, or it may be because of
what is more common? What is more common?
sir, ischemia to the bowel segment, sir, and that might have led to the decrease the peristalsis, and that led to the
Patient will
obstruction.
not go till day 6. He have bowel ischemia. He will be in ICU in day 2 or day 3.
Ileus is more common, sir.
Yes, sir. Yes, sir.
Why not fecal impaction in the rectum?
Okay, sir.
That is more common than having a real mechanical obstruction, some surgical cause. Because we have done bowel surgery and these patients are generally constipated. So one more thing which I started doing, asking about any addiction of the for passing motion. Some people smoke, some people want because they are old people. They mostly have reflex of passing motion. Some only read newspaper. Some only drink tea. Some smoke. Some have tobacco for that, and some are chronically constipated. So rule out those things first, then CT scan followed by finding the other causes. I'm just not a example. I'm how to practical approach in these patients. Okay. बख्शी सर शॉर्ट ऐड करेंगे आप कि इट इज ओके? बख्शी सर कुछ something like to add, or we can go?
Go ahead.
Okay. Okay.
Yes.
What was CT scan finding? Yeah.
Sir, he was diagnosed with obstruction. Sir, the CT scan films are not available with the.
Okay. What was the finding?
Sir, patient underwent exploratory. We have a video from the laparatomy, sir.
Okay.
Yes, sir. This was the loop, sir. That.
So mesenteric window was closed when the ileal segment was taken down.
When I was trying to press this, it was not going. You see, હવે આ window અહીંયા છે. I'm just pushing and turning it around. ઠીક છે. હવે જો. Now it is going. Good. See, now it's getting empty, no? No, open full થઈ ગયું. So the light should have been like this. આને આમ કર દે. અને આમ કર દે.
What is end-to-end side-to-side anastomosis?
Look like a stapler anastomosis.
Yes, sir, but end-to-end side-to-side.
वो तो साइड टू साइड पता नहीं साइड टू साइड कैसे
not able to
So we did an exploratory and the end-to-end ileal anastomosis was taken down. This anastomosis was taken down and end-to-end ileal anastomosis was done, sir. 10 to 15 centimeter with ICU.
No, I'll tell you, Mahendra. Normally means it was not it was side to side anastomosis, but how you pray, that way it was anastomos, not overlying each other.
Okay.
So, and the mesentery, that time also we saw one side mesentery was closed. Second time we thought that second side, okay, one side we are already closed, it will not cause any problem. But that only had caused a problem, and the patient had obstruction.
Okay.
So we did resection anastomosis, and patient was fine, except that patient had some discharge from the wound, And Swastik, just show them the histopathology report of the
Yes, sir.
radical cystectomy that you
Yes.
have not shown them.
Sir, yes, sir. This is the report, sir.
Can you just read it out?
Yes,
Because
sir.
it's little difficult to.
Yes, sir. Yes, sir. So the procedure was radical prostatectomy. Tumor site was left lateral wall and posterior wall. Tumor size was in 2.3 centimeter greatest dimension, and it was a high grade urothelial carcinoma. It was invasive, and there were no lymph node metastasis. There was the lymphovascular invasion was present, and the margins were involved by non-invasive low-grade urothelial carcinoma. It was a right ureteral margin. It was involved with non-invasive low-grade urothelial carcinoma. Urothelial dysplasia was seen. All other margins were uninvolved by the invasive and in situ carcinoma. The diagnosis was high-grade invasive urothelial carcinoma of bladder with involvement of prostate parenchyma and 21 negative pelvic lymph nodes, PT4A, PN0, PNMX. This was the staging, sir.
So this tumor has involved muscle, perivascular soft tissue and prostate, right?
Yes, sir.
Report पे लिखा है vagina, PT4. Is a male patient, no prostate?
Yes, a male patient, sir. It was
Okay, maybe some mistake. Okay.
PT4A, sir. They were staging, I think.
And see, there was some involvement of the right ureter in this. Actually, it should have been a left ureter.
Sometimes, sir, the labeling for the frozen or something also wrong. So it is not frozen, right?
No, sir. It is the full histopathology report, sir.
Okay, okay.
They must have written the staging, sir, in both PT4A because it is written both prostate and uterus and vagina.
Okay, fine.
Okay, fine. So now this patient recovered and he was advised adjuvant chemotherapy, and he was regularly undergoing this chemotherapy. Now, the next history.
So the patient again after 2 months presented with pain on the right side of the abdomen and with right flank pain, sir. And
okay, so Saswat Sai, this is a thing. After getting I think about 4 chemotherapy, he started getting pain in the right lumbar region and right flank. So now what you will do?
First,
What
sir,
is your
do you think?
what you are suspecting?
Yeah, what do you think in this stage?
Sir, it may be because of the anastomotic structure which might have led to the hyperureter necrosis and leading to the flank pain. So I'm thinking in that way. So I do the ultrasound abdomen and pelvis at first to have the clinical clue.
Anything else by the biopsy report? If you see HPR,
Sir, maybe left ureter is involved, so maybe right ureter may also be involved in this case. And so sorry. The tumor is in the left side.
no, but the biopsy report right was involved, right?
Yeah.
So, sorry, sir mentioned that it was a left ureter, so that's why I'm not thinking in that way, sir.
Okay, so it can be recurrence or can
Yes,
be?
sir. It can be recurrence. Yes, sir. It can be recurrence or it can be ureteral anastomotic structure, sir.
Anastomotic structure. So now some examiner may ask you about the cause of strictures. Okay.
Yes, sir. And
tell me, because this is related to cystectomy. Yeah. Tell me the cause of stricture.
Sir, during the time of anastomosis, the ureter may not have been adequately spatulated, or there may be some leak. There may be some minor leak from the ureter, or there may be some infection which might have led to the stricture at the level of anastomotic side.
Which is more common cause of among these, whatever you said, more common cause of stricture ureter is a blood ischemia.
Sir. Yes, sir. Okay. Ischemia, sir.
Ischemia. Okay. Yeah.
Yes, sir.
So
see,
now
the first thing maybe during anastomosis the ureter has been twisted.
Yeah.
That is number one. Number two, as you said. Number two, as you said, the anastomosis, the lumen may not be wide enough. Third thing is this ischemia, because when you do too much of dissection of ureter, okay, and sometimes you may go subserosal, you may damage the blood vessels. That is the third. Okay. Fourth will be
anastomotic leak and then led to the
anastomotic, some leak might be there, and secondary to that there may be a stricture formation. Now in this case it can also be after this thing, exploratory laparotomy, there was a discharge from the wound. So
Wound,
that
sir.
also
Okay,
might
yes.
have caused infection and caused the stricture. And the last is that the histopathology is showing some positive margin of the ureter.
Yes,
So there may be some recurrence. Okay, fine. So now next what you'll do ultrasonography. So what
Yes,
was
sir.
the report of sonography, Swastik?
It was sensitive right hydronephrosis and hydroureter. No calculus, no mass was seen. Left kidney was normal. This was the brief report of the ultrasonography of pelvis.
At this stage, some examiner may ask the patient is having T3A disease, receiving chemotherapy, and if creatinine is normal, why in this case CT scan was not done upfront? What additional thing you would like to gain by the sonography, not by the CT scan?
Any filling defects which in the ureter, sir, which are
Sonography.
concomitantly associated with the bladder seal.
Sonography filling defect.
Oh, sorry, sir. Okay. Sonography.
No, you should tell why was sonography not CT scan was done.
See, the patient has got right-sided pain. That doesn't mean that it is always. So we want to do sonography to find out the basic cause, whether it is a kidney related or it is something else.
So
and then we will decide doing
sir.
the further investigation. So in an exam, you can justify yourself. Just because patient has, we have operated him, that doesn't mean that patient has got only the kidney related pain. It may be something else. So by doing sonography, you are not doing wrong thing. And then depending on that, you can decide your further management, or you can decide regarding the further investigation.
Yes, sir.
Okay, so now this is the thing. What, Sai, what do you want to do?
Sir, I want to have the serum creatinine report and then I'll do the CT urogram in this case.
Yeah, creatinine was normal. Normal, na, Swastik?
Yes, sir, creatinine was normal, sir.
So would you like to do CT scan, CT KUV, IUV, or you want to do CT abdo-pelvis?
Sir, CT IVU, sir.
CT IVU?
CT urogram in this case.
But not abdo-pelvis with the IVU?
If you are 100% damn sure the problem is in the lumen, then CT IVP. If you are not sure, then CT abdomen pelvis with CT IVP. So better answer is CT abdomen pelvis with CT IVP.
Okay, sir.
You are dealing with malignancy, and 2 months microbats can get anywhere, like liver, and if you miss the liver mets at present, and some other person will do after 1 month, you are in trouble. Okay.
Sir. Okay, sir.
Yeah.
Yes, sir.
Yeah, fine. So we are now yet to do CT IVP, but before that, we have done right PCN and tried to do antegrade degescenting. By show them film.
So this was the antegrade. Yes. There was abrupt cutoff, sir. The right side, sir. Right ureter.
So now we have kept the nephrostomy. And as all of you have suggested, we will go ahead with the CT scan. But my question is, Ganesh bhai,
yes, sir.
Now what? What I should do? He's already undergone twice exploration and chemotherapy and all. So how difficult it will be, and what are the options?
Difficult to ठीक है sir मतलब.
So what do you think? Means once the CT scan we show and there is nothing much, then we should go inside.
Maybe. Finally, better treatment.
Okay. So anyway, we are waiting for the kidney to see how much it is functioning. And we, as you suggested, all of you, we will do CT abdomen pelvis workout, and then maybe we'll put forward that this was the finding. Take suggestions from you and go ahead.
Any role of minimal invasive technique or surgical options?
One thing what we are thinking is to now put the methylene blue from above and then do the flexible ureteroscopy to put it into the conduit and see if by chance if we are able to see some methylene blue coming inside the lumen, to find out from where it is coming and do some retrograde procedure, or put the flexible from above and go inside and see whether we can do something.
So difficult है मतलब.
बहुत difficult है.
With that cutoff, it's difficult.
So आप भी बताना मेरे को कि what you would have done, and let us see with some more experienced person we'll go inside.
I think we should wait for the PCN with PCN sometime.
Yeah, so I am waiting for this PC system and the thing, but nephrostomy, I am going to do CT scan and then we'll decide.
Sir, just my query, any role of breast cytology, because the margin was positive right side.
So, okay, so now as you suggest, now I will do that also. What I will do that I will put the like ureteric catheter I can put over the guide wire. I'll go right up to the bottom.
Cutoff point.
Yeah, cutoff point, and aspirate and send it for the cytology. Okay, or I'll try to do antegrade this thing, flexible ureteroscopy, and if possible, we'll do something. I'll let you know what we are doing.
Okay, sir. Okay.
So in this case, robotic cystectomy done?
Yeah, everything was robotically it was done. And then we did the laparoscopy also before exploration. But then, things were so much adherent and we were afraid that we might damage the ileal conduit and ureter. So that is why we just opened up wherever the lesion was and did the anastomosis.
Why I am asking, because when the discussion is going on the radical cystectomy, the options available are laparoscopic, robotic, and open. So anyone can tell, I will explain the possibility or availability of laparoscopy, robotic. Patient, if he insists for that, I will refer him to the particular place, and what he will do is open radical prostatectomy, because current practice also suggests that the open radical cystoprostatectomy and laparoscopic and robotic is under evolving procedures and can be done by some expert person and expert place.
Okay, fine. So I think in exam what you are saying is right. That is the answer. Fine.
Yes.
Okay, now Ganesh bhai, we have got 2 cases, but we'll finish very fast. And your opinions we want. They are 2 nice cases. Okay, Swastik, go fast.
A 69-year male businessman with occupation presented a history of on and off blood in urine, which was painless, intermittent, complete, and associated with clots for 2 months. Difficulty in passing urine for 1 month, and IPC score was 14 out of 35, and bothersome score was 2. Patient was a known case of Alzheimer's disease. He was taking medications for that. Post-operative status, TRP was done 2 years ago. On examination, general examination was within normal limits. CNS, CBS, and respiratory system were within normal limits. Per abdomen, soft, non-tender, no palpable lump was present. No ring line tenderness was present. Per rectum, there was no fissure, no fistula. Prostate grade 1 enlargement. Firm, mucosa mobile, no blood gloves. Hemoglobin was 12. Total count 7,000. Platelet count 3.6 lakhs. INR was 1.2. Sodium, potassium, and creatinine were normal. Serum PSA was 0.98. Culture sensitivity showed no growth. Cytology was showing no atypical cells. This was the urine routine. There were red blood cells 14 to 16 per high power field and 10 to 12 pus cells were there per high power field. This was a uroflowmetry cell, and patient came with this ultrasonography.
Yes, anyone can comment on that?
So this is an ultrasonography images of the KUB region, sir. The kidneys bilateral appear normal, sir. There are multiple lesions, sir, seen on the upper left lateral wall, sir, and the dome of the bladder, sir, and also inferiorly, sir, on the bladder wall. Sir, vascularity is not mentioned, not depicted, sir, in these plates, and they are broad based, sir.
Okay, fine. So now this is the sonography. Next, what you want to do?
Sir, cytology and upper tract imaging, sir.
So in this case, you want to go ahead with the TURBT, or you want to do CT scan followed by TURBT?
Sir, because there are multiple large tumors, sir, and patient is having gross hematuria, sir. So I'd like to go for a upper tract imaging with the CT urography, and then go for a cystourethropy and TURBT, sir.
So you want to do cysto only CT urography, or you want to do CT abdomen pelvis, and you
CT
like to do
abdomen
even
pelvis,
extended?
yes, sir.
Means up to the chest also.
Sir, chest we can, sir, actually for staging purposes, sir, CT chest is recommended, but without histopathological diagnosis, sir.
Yeah, you can do a chest CT later on also, no problem.
Yes, sir.
So, but basically you like to do CT, abdomen and pelvis, correct?
Same thing, triphasic with the delayed.
Okay. Swastik, show them.
The patient underwent a TURBT before going for further scans, and it was sent for biopsy. The biopsy was suggestive of microscopic appearance. It was suggestive of high-grade invasive urothelial carcinoma, sir, and carcinoma was involving lamina propria reaching out to the muscle cord. Lymphatic tumor embryos were also noted in the biopsy. The same specimen was again reviewed, and it was suggestive of invasive high-grade papillary urothelial carcinoma with invasion of the detrusor muscle.
Papillary urothelial. Okay. Okay. So CT scan. This is CT scan, na? Histopathology.
Histopathology, sir.
CT scan.
Not done, sir. Sir, not done.
So patient also had undergone a DTPA scan before presenting to us, and the GFR was 35.5 on the left side and 31.9 on the right side. Total GFR was 67.4 milliliter per minute, and the differential function on left side was 52% and right side was 47%.
Okay. Is there any role of DTP in such case?
Until and otherwise indicated, there is no role of DTP scan in this patient.
Not a mandatory investigation.
And not a mandatory also.
So answer is only when patient may going to receive chemotherapy.
Yes, sir.
Okay.
Yes, sir.
Yeah.
This CT scan is done after TURBT.
Yes, sir. This was that was done, sir.
In such big tumors, it is preferable to do a prior.
Okay, sir.
Show the film na, barabar.
Yes. These are PET CT scans, sir.
PET CT.
Yes, sir. PET CT was done, sir.
Okay.
Patient came to us with all these investigations, sir.
इसमें तो ये भी लिखा है large size nodular lesion from prostate also seen.
Yes, sir. He also already had a history of TURP, sir, 2 years back, sir.
And अभी के स्कोपी में prostate देख चुके हैं ना, तो prostate is normal, right?
Yes, sir.
Huh?
Yes, yes.
So that must be, if it is really a lesion, it must be a clot.
Exactly, sir.
Okay.
Yes, sir. So the patient came to us and he also underwent a radical cystoprostatectomy, sir. And the histopathology report was suggestive of a prostatic. There was no amount of prostate. The prostate was free of tumor. Along with this microscopic description was there. The tumor site was right lateral wall and left lateral wall, along with the anterior wall is involved. The histological type was urethral carcinoma, invasive, high grade, and the margins were uninvolved by invasive carcinoma and carcinoma in situ or non-invasive urethral carcinoma. Bilateral urethric cut margins were free. Urethral cut margin was free. And bilateral vas difference cut margins were free, and in soft tissue margins were free. Lymphovascular invasion was present, and number of lymph nodes involved were 0. Total number of lymph nodes examined by 29. And the staging was PT2B N0MX, high grade invasive urethral carcinoma of urinary bladder with clear margins, and 29 negative pelvic lymph nodes.
Okay.
So already done everything. What next? Chemotherapy? No chemotherapy.
PT2B लिखा है ना?
जी sir.
शाश्वत.
What is T2B?
So T2B is involving outer half of the detrusor muscles.
So what will you do next?
0 and CMX, M0.
Yeah. So you have two options. Either give adjuvant therapy or just to observe.
Observe.
Yeah, क्या करोगे? What will you do?
Sir, I'd like to observe the patient. Sir, patient is a case of Alzheimer's disease also. So,
अरे अल्जाइमर की वजह से ऑब्जर्व मत करो. You can say broadly it is PT2,
yes,
N0 and CM0. So stage becomes 2.
Yes, sir. Stage 2 tumor.
Unless it is PT3.
Yes, sir.
In bladder, there is no adjuvant indication or indication of adjuvant therapy.
Yes, sir. Margins are also free, sir.
Free.
Yes, sir.
And nodes are also all negative.
Nodes are negative. Yes,
so
sir.
that is it.
So tell clearly, na? There is no role of
Alzheimer पे मत जाओ. Be clear लिखी. वही तो.
ठीक sir.
How will you follow up this patient?
Okay, now I just want to give the history. This patient had a distension, mainly the upper abdominal distension, for 4 to 5 days, 6 days. And
after
every day
cystectomy?
After cystectomy, and continuously about 1.5 liter, 1.2, 1.5 liters of secretion used to come in the Riles tube. Okay. So we did a 2-time CT scan with the contrast, oral contrast, and it was not going beyond jejunum. So Shashwat, can you tell me what is your probable diagnosis?
Sir, there could be some so properly, if it was not retroperitonealized, there could be some internal herniation or a volvulus or some
Okay, I'll give you one more history.
Additions, sir.
I will give you one more history that the Riles tube was clamped during this procedure, during CT scan. And then Swasti, I think Paras, he just readjusted the Riles tube and 800 cc of fluid came out.
Maybe in the judgment.
See,
Yes, sir.
on 8th day, patient started passing gases, stool, everything, and continuously had a good peristalsis. So our presumption is that patient had an acute dilatation of a stomach. So that is why whatever contrast we were giving, it is remaining in the stomach and not, going very slowly ahead. So that is why after a few hours when we were taking films, it was showing only up to the jejunum. It was not going even up to the anastomotic site,
Okay, sir.
So without doing anything, after a 7th or 8th day, patient improved and started passing stool, everything settled down. And most of the time, this is retrospective. It was only the upper abdomen. Lower abdomen, we were taking regularly, means every 2 hourly abdominal girth, it was constant. But we can see that there is a distension of abdomen, and that mainly in the upper side. This is just for your reference, so that when you come across such cases, this is one of the things you have to understand.
Gastroparesis is reported complication after long major surgeries, and this patient have already Alzheimer, old age, supramajor surgery, long duration surgery, electrolyte imbalances, neuronal problems. Gastroparesis is reported.
Yes, sir.
Yeah.
So you should keep in the mind and treat accordingly. Ganesh sir, anything?
नहीं sir, मुझे भी वही लगता है मतलब.
Yeah, retrospectively, first case we explored. Both the cases were quite nearby. They were like 4-5 days apart, and we were so much afraid that one case already explored, second case also we have to explore. But luckily, he settled down and went home.
Sir, ये tobacco chewer नहीं है ना?
No, sir.
Swastik?
No, sir, he was not. Sir, he was not a tobacco chewer, sir. Only Alzheimer's history was there. And one thing, sir, that sir has already pointed earlier, he had that habit of taking he was very, very much giving importance to taking water on and off from the 2nd or 3rd day. He wanted water like anything. So sir also mentioned that taking a lot of water in post-operative period can lead to this kind of ileus and all. So
yeah, so we had told him to take hardly 15-20 cc every like half an hour. He used to take half a glass of water like that, because he was feeling very thirsty, and because he had Alzheimer, we were not able to control him. He used to become very violent. So the relatives used to give that, and patient had such this history of distension from the beginning. The wife used to tell us, no, this is happening so many times, so you don't worry. It is not an obstruction. She used to tell us.
Electrolytes during that period are normal?
Yes, electrolytes,
normal.
Everything was normal, sir, in that period, sir.
Okay.
Fine. Okay, so let us go to the last case. Swastik.
Yes, sir. Third case, sir. 84-year male presented with blood in urine for 7 days along with difficulty in passing urine. Hematuria was painless, complete, intermittent, and was associated with clots. General examination was within normal limits. Systemic examination, a bladder lump was palpable. So a Foley catheterization was done, and hematuria with clots were present. Patient underwent cystoscopy and clot evacuation. A large mass was seen involving bilateral ureteric orifice. Bilateral VUGA could not visualize during the cystoscopy. On blood investigations, the hemoglobin was 7, total count was 8,000, platelet count was 1,49,000, and serum creatinine was 7.8, and INR was 1. Urine routine microscopy showed innumerable red blood cells and white blood cells, and this was the USG report, sir.
Just read out the USG report.
Yes, sir. Both kidneys were grossly hydronephrotic and showed thinning of cortices with increased parenchymal echogenicity. No evidence of intrarenal calculus or mass noted. Right kidney was 11.7 into 6.6 centimeters, and left kidney was 11.2 into 6.1 centimeters. Both ureters were dilated and tortuous along their entire extent up till the UV junctions. Bladder was partially distended. 14 cc post catheter clamping was done. Foley's catheter was noted in situ. There was extensive polypoidal thickening of bladder wall. These masses show basal intrinsic vascularity. The polypoidal mass involving all segments of urinary bladder, larger ones as follows: 5.8 into 3 centimeters along the anterior wall, 2.7 into 2.8 centimeters along the right posterior wall, and 3.4 into 1.4 centimeters within the wall of urinary bladder anteriorly. Prostate was enlarged in size. It was corresponding to 78 grams. So impression was grossly hydronephrotic kidneys bilaterally along with bilateral hydroureter, consistent bilateral outlet obstructions due to multiple urinary bladder wall masses. Both kidneys showed medical renal disease and prostate was enlarged.
So Shashwat, next what do you want to do?
Sir, I want to have a look at the serum electrolyte, sir. And if there is any dyselectrolytemia, I'd like to correct that. And then I'd like to, sir, counsel the patient about the the chronic kidney injury, sir, CKD, and proceed for decompression.
You want to do dialysis or you want to do decompression?
Sir, bilateral PCN, sir. If there is, sir, no any dyselectrolytemia, which is not amenable to medical therapy, or there is severe metabolic acidosis, in that case only, sir, I'd like to go for dialysis, sir, first. Otherwise, if I can go for sir, bilateral PCN also.
So if electrolytes are normal, if patient condition otherwise stable with of 7.8, then we would probably go for a PCN.
Yes, sir.
If condition is unstable, electrolytes are getting out of range, that probably might push you acidosis, that might push you to dialysis.
Yes, sir.
Okay.
So in this case, patient was having normal electrolyte levels. So patient underwent a bilateral PCN and gradually serum creatinine was reduced to 3.2 over 7 days.
What next?
Yeah. So now this is a story. He is 84 years old male.
Patient is fairly fit for surgery. Probably cystectomy still can be done with a peri-op ICU and dialysis cover. If he is not so fit, then probably we will have to do a maximal TURBT and think about some radiation.
So these are the two answers, students, you should know. Okay, if the patient is fit, then we can go ahead with the radical cystectomy. If he is not fit, then as Dr. Ganesh said, do whatever maximum you can do it, remove the mass, and then go for the radiation.
Yes, sir.
Yes.
So in this case, radical cystectomy was done.
Yes, sir. Radical cystectomy, robotic radical cystectomy with bilateral ileal conduit was performed. Before that, sir, the patient had underwent a PET CT scan, sir. PET scan was done, and it was suggestive of a high-grade metabolically active lesion was seen with significant thickened urinary bladder walls, consistent of known urinary bladder carcinoma, and there was moderate increased metabolic activity noted in prominent subcentimeter right side and external lymph nodes, suggestive metastasis. And yes, sir, the patient had underwent a radical cystectomy with ileal conduit, sir.
And
So, Ganesh, in this case, when already metastases are there, still you should go ahead with the radical cystectomy.
नहीं sir, metastasis था मैंने miss किया, sorry.
So, lymph node metastasis were there, sir. Yes, sir.
Yeah, मतलब 84 years में we are not going to probably give him chemotherapy.
So Ganesh sir, is it only a salvage cystectomy with small ileal conduit?
कर सकते हैं मतलब अभी क्या?
Okay, creatinine 3.4 in spite of bilateral PCN. So standard length ileal conduit may not be a good idea. And another thing is for any urgent things, any urgent in this patient is
not going to be possible. Adjuvant is not going to be possible. So whatever cystectomy, but metastasis बोला ना सर ने वो miss किया मैंने.
जी सर.
So PET CT, I didn't realize that PET CT shows metastasis.
Sir, it was a left
Pelvic.
subcentimetric
Pelvic
size,
node
right,
में
sir? Yes, sir. External iliac lymph nodes were there, sir. Likely suggested.
साइज क्या लिखा है?
Sir, subcentimetric size लिखा है, sir.
Sub-centimeter size ठीक है. So मतलब main issues is again 84 years. Second is higher creatinine, peri-op ICU and peri-op dialysis. So 4 things are main issues.
Okay. So still you can, in the exam, one can say that if the patient is otherwise fit, there are no.
Sir, you will have to defend it. Matlab 5 centimeter mass, 3 centimeter mass. This is going to be causing symptoms, repeatedly bleeding, hemoglobin dropping, everything. So then that is a better treatment.
Fine. Okay. So I think your answer is perfect. If it is a fit, better to go with a cystectomy. Is not fit, do maximum resection and do radiation therapy.
Sir, ये पहले क्या हो गया सर्जरी?
पहले I think biopsy हुआ है और कुछ नहीं हुआ.
नहीं, इसका सर्जरी अभी हुआ है क्या?
Yes, sir. Patient operated.
हो गया.
Yes, sir.
तो इसका पोस्ट ऑप कैसा है?
Sir, post-op, sir, recovery was good, sir. Patient has been discharged, sir, from our side. Post-operative, sir, wound was normal, and urine output from the was normal, sir. He was discharged with a creatinine level of 2.3, sir, and
no ileus.
No ileus, sir. He passed status on day 4, sir, and passed motions on day 5. We allowed liquids to him on day 4 after passing flatus, and yes, sir, his recovery was uneventful, sir, post-operatively.
Okay.
Yes, sir, he was a very well-built man, sir, with a Karnosky score of around 80, sir. So,
okay.
Was he a farmer?
Sir? No, sir, no, sir.
By occupation?
No, sir, he was not a farmer, sir.
He's 84 healthy person. He was physically active.
Yes, sir.
So prior to cystectomies had ileus, right?
Yes, sir. 2 had ileus, sir. First was obstruction, second was ileus, sir.
Okay. So in cystectomy, there is a good chance of complications. Peri-op complication rate is something like 25%. If you translate that into simple language, 1 in 4 patients is going to experience some severe complication even in a high volume center. So
okay,
that is how probably we should counsel the patient. And I don't know, but many times seen ileus happening with robotic cystectomies.
You've seen it, no?
Yes. I mean,
I always thought.
we had done 2, 3. Remember, Mahendra, every patient used to have prolonged ileus. I don't know.
No, because I thought that we are not handling too much of intestine in robotic and we are not exposing it to atmosphere. The chances of ileus and other things should be very less. That was my logical thinking. But now, as you are saying, we are also experiencing. Means when
and another thing is one age-old thing. I don't know whether it really affects, but one age-old thing which we used to always follow in a cystectomy is lateralization and loop fixation for internal herniation. That step is totally skipped in the robotics.
Correct.
So we sometimes I think that is it the cause of this?
Okay, fine. So next time we should think of that.
I don't know, sir. In robotics, that step is not done.
No, we are not doing. Correct. Lateralization
nobody
and
does.
fixation.
Nobody does. But in open, we do it. I don't know. Open, we do it religiously.
And it's possible. Like
do
you can see.
And we also do retroperitonealization. So these 2 steps which happen in open surgery, they don't happen in the robotic version.
Yeah. Fine.
Mahendra, तुम्हारे comments दे सकते हो तुम वो.
No, sir. After these 2 things, हमारे काफी जो paracondyl hernia थे, वो सब जो है काफी कम हो गए. Very less. मतलब no, I will say.
नहीं, but robotic cystectomy और ileus की बात चल रही थी, इसलिए बोला. And as far as the IROC study goes, I think at 12 weeks everything is same. Robotic हो या open हो.
Robotic only has a benefit in a early recovery. Otherwise, all outcomes are almost same. And the blood loss.
Early recovery, less blood loss, but less blood loss. Like if Mahendra operates, blood loss is same as robotic.
Yeah. Because of you, you taught me like that only.
Yeah. Of course, my experience is not very vast. We have done only like, about 12 to 14 robotic assisted radical cystectomy. But in your Tata, you must have done so many.
Thanks, sir.
So-
We, by choice, we used to do prostates and nephron spares. For cystectomy, we readily never offered robotics.
Okay. Fine. So now, Doctor, if Pankaj is there, Pankaj, you want to give some advice? Or Dr. Hudedar is also there.
Pankaj sir,
पंकज भाई there है कि नहीं है?
गौरंग भाई, गौरंग भाई,
11 बज गए.
Yes.
गौरंग भाई.
इसलिए last to comment from them from the
Hello.
stalwart and we close it down. Yes.
Hello, Gaurang bhai.
Yeah.
I appreciate the stamina of Dr. Ganesh Bakshi. He had given one lecture on CA prostate just before our program. It was
sir,
the
नहीं,
duration of
मैं आज थक गया हूँ.
1 hour and 20 minutes. And my student was actually Gyanendra Sharma. He was actually in that program. And I enjoyed that program. And
Yeah,
again, with enthusiasm, what enthusiasm he is answering all this one and giving us the knowledge. Very good.
थोड़ा थक गया हूँ अभी.
That is an advantage of working in Tata, na?
Yeah, yeah.
You don't get tired so fast. Because he used to, I'll just tell you, he's my mentor as far as robotic is concerned. After
yeah.
finishing 4:30, 5 o'clock, he used to come to Saifi. I used to take 10, 11 hours to
And we used to
complete the
spend nice
surgeries.
time together. बहुत सीखने को मिला लेकिन sir.
Up to 1 o'clock, he used to be with me.
Yeah, yeah.
So
Very
I know
nice.
him well.
Yeah.
Thank you, Ganesh, for whatever you are doing for the students.
सर अगली
and
बार
what you
एक
have done for.
आप रोबोटिक सिस्टेक्टोमी एंड इंट्राकॉर्पोरियल कंडक्ट करते हैं, एक छोटा सा 10 मिनट का एडिटेड वीडियो दिखाओ ना नेक्स्ट टाइम.
Okay, we have got that fine, good video. I'll just show it. I'll tell Tanvi. Tanvi has got one. So we'll start it with this, and probably can we go ahead with the chemotherapy of all
हाँ,
the
चलेगा सर.
next time, Ganesh?
चलेगा. मैं विजय को भी पूछता हूँ, विजय पाटिल को.
हाँ, उसको ही पूछ लो. And then if we get some metastatic, just 10 minutes presentation of metastatic CA bladder, followed by chemotherapy of that, then upper tract TCC, and maybe little about RCC.
चलेगा.
So you please let us know. So we'll put it on a group.
I'll ask him tomorrow. No problem.
Yeah. Okay.
Okay. Good night.
Thank you, sir. Good night.
Good night. Good night.
Thank you, sir. Good night.
Thank you, sir. Good night.
Good night.